We'll be looking at depression briefly. My name is Dr. Peter Boakye-Boama. I'm a medical doctor and a resident in the psychiatry department in Kumasi, Ghana. My email is peterboakye27@gmail.com. Now, the outline of the presentation. 1. Definition. 2. Etiology and epidemiology. 3. Pathophysiology. 4. Types. 5. Diagnostic criteria. 6. Signs and symptoms. 7. Investigations. 8. Complications. 9. Treatment. And finally, 10. Prognosis. Depression is a mental health condition characterized by persistent feelings of sadness, low energy, loss of interest in activities, and a range of other symptoms that interfere with daily life or functioning. The etiology. Depression is a complex condition with no single known cause, but rather a combination of factors that contribute to its development. These factors include genetic, brain chemistry, stressful life events, and medical conditions. Details of the etiology. Biological factors such as brain chemistry and genetics, hormonal changes and medical conditions. Then psychological factors like stressful life events and personality traits and negative thinking patterns. 3. Environmental factors like social isolation, adverse childhood events and substance use, and other factors like medications and lack of sleep. Epidemiology. The prevalence of depressive symptoms in the general population is about 30%. The male to female ratio is 1:2. This is because of hormonal fluctuations, higher genetic predisposition, and poor coping mechanisms in females. About 280 million people worldwide experience depression. Pathophysiology. Currently recognized mechanisms that aim at explaining a pathophysiology of depression include biogenic amine hypothesis, dysregulation of the hypothalamic pituitary adrenal axis, and genetic and environmental factors. These mechanisms do not totally explain it individually, but they come together in an attempt to try to explain them. Types of depression. We have major depressive disorder, MDD, persistent depressive disorder, PDD, the bipolar disorder, seasonal affective disorder, SAD, postpartum depression, psychotic depression, then premenstrual dysphoric disorder, PMDD. Now the details of the types. Major depressive disorder, MDD. It is characterized by persistent sadness, loss of interest, and other symptoms like sleep and appetite changes for at least 2 weeks. Persistent depressive disorder, PDD, also known as dysthymia. Here, a chronic low-intensity depression lasting for at least 2 years in an adult or 1 year in a child. When it's comorbid with major depressive disorder, it is called double depression. Then bipolar disorder. This involves shifts between depressive episodes and manic episodes. Seasonal affective disorder, SAD. Depression is related to changes in seasons, especially the winter months. Postnatal or postpartum depression. Depression that affects new mothers, fathers, or partners after childbirth. Psychotic depression. a form of depression characterized by the presence of psychotic symptoms alongside the usual symptoms of depression. Premenstrual dysphoric disorder (PMDD), a severe form of premenstrual syndrome with most symptoms like depression and anxiety. Then recurrent depressive episodes. This refers to repeated occurrences of major depressive episodes where a person experiences depressive symptoms for at least 2 weeks with periods of remission in between. Then atypical depression. This is characterized by hyperphagia, hypersomnia, leading paralysis, and emotional reactivity to neglection. Now, the diagnostic criteria. The core symptoms of depression are depressed mood, low energy, and loss of interest in previously pleasurable activities, classified as A. Then B, with symptoms of reduced concentration, reduced self-esteem, self-harm, disturbed sleep, and diminished appetite. For mild depressive episode, a patient must have at least 2 of A and at least 2 of B. For moderate depressive episode, at least 2 of A and at least 3 of B. Then for severe depressive episode, at least 3 of A and at least 4 of B. Signs and symptoms continued. We have depressed mood, decreased energy, anhedonia, which are the core symptoms, and other symptoms like disturbed sleep, appetite changes, weight changes, reduced concentration, psychomotor agitation or retardation, feelings of hopelessness, helplessness, or guilt, and suicidal ideas or plans. Other signs and symptoms like somatic symptoms include loss of emotional reactivity, psychomotor agitation or retardation, loss of appetite and weight, and loss of libido. Psychotic symptoms of depression include both delusions and hallucinations. It is worth noting that there are mood congruent symptoms and mood incongruent symptoms. Mood congruent symptoms include delusions of guilt, worthlessness, hypochondriasis, nihilism, and poverty. Then hallucinations like auditory hallucinations, visual hallucinations, and olfactory hallucinations. Mood incongruent symptoms include deletions of reference, persecution, thought insertion, withdrawal, and voices speaking about affectively neutral topics. Other features or signs or symptoms include significant anxious distress, catatonic symptoms, marked psychomotor retardation, and marked depressive stupor. Investigations usually focus on exclusion of treatable causes, that's a differential diagnosis, and other secondary problems like loss of appetite and alcohol misuse. Standard investigations include full blood count, BU and creatinine, LFTs, TFTs, glucose, B12, calcium, and ESR. Focus investigations using your history and physical exam include urine toxicology, thyroid antibodies, syphilis serology, and CT or MRI. Complications of depression include mental and emotional health problems like suicidal thoughts, substance abuse, anxiety disorders. Physical health problems include increased risk of chronic diseases, pain, premature death. Social and personal function problems like relationship difficulties, work and school problems, and social isolation. Treatment involved using assessment tools like the sad person scale, the Hamilton's rating scale, and the Beck's depression inventory. Treatment, the general factors. For mild depression is usually psychosocial management. For moderate and severe is psychotherapy plus pharmacotherapy. Indications for inpatient admission include risk of suicide, risk of harm to others, severe depressive and psychotic symptoms. Continuation of treatment. Psychological approaches include cognitive behavioral therapy, interpersonal therapy, and dynamic psychotherapy. For biological treatment without psychotic symptoms, antidepressants like SSRIs, fluoxetine, sertraline, and citalopram are used. TCAs like amitriptyline are used, among others. With psychotic symptoms, antidepressants and antipsychotics are used. Antipsychotics such as quetiapine, aripiprazole, risperidone, and olanzapine are used. Physical therapies include ECT. Social therapies include family supports and occupational therapy. For maintenance treatment, for the first episode, you continue effective treatment for 6 months to 1 year after remission, particularly if there are residual symptoms. Then discontinuation should be gradual, and if there is occurrence of symptoms, you revert to effective dose with attempt at withdrawal for at least a further 6 to about 6 months. Recurrent episodes. If the period between episodes is less than 3 years or with severe episodes like suicidal ideations and actions, prophylactic treatment should be maintained for at least 5 years. Treatment-resistant depression. This is failure to respond to adequate courses of 2 antidepressants or 1 antidepressant and ECT, where adequate courses means maximum dose for at least 4 weeks. Prognosis. The prognosis for depression varies, but is generally treatable with a good outlook for many, especially early intervention and appropriate treatment. However, some individuals continue to experience chronic or recurrent episodes, and suicide remains a significant risk, particularly without treatment. Good prognostic factors include acute onset endogenous depression, early onset of symptoms, and treatment seeking and adherence. Poor outcome includes insidious onset, neurotic depression, elderly, residual symptoms, neuroticism, low confidence, and lack of social support. The prognosis again. Possible outcomes of depression. There can be full recovery, there can be partial remission, there can be relapse, and there can be chronic depression where the person experiences persistent and ongoing symptoms that are difficult to treat. At this juncture, we come to the end of our presentation, and as usual, our quote is protect your mind, for it is your own. Thank you very much.